Okay, well, welcome everybody. We're going to go ahead and get started. If you have not done so, please put your name and contact information into the chat. We really welcome you today to our session of Project Scope. We are recording this for educational and quality improvement purposes. So by participating, you are consenting to being recorded. If you can take a minute and rename your profile with your name and where you're from, and if you also want to put your discipline, that would be great. We are trying to build that community of practice, so it helps us understand where everybody is from and get to know each other via Zoom. If you've ever participated in one of our sessions in the past, we hopefully have you guys engaged with that. You can put questions in the chat box, raise your hand, or reach out to one of the hub members that has an asterisk in front of their name, and we'll be glad to help you with anything. Another way to just solidify our information are those case narratives. We are not having a case narrative today, but in the past and in the future, we will always have a case where we will talk about clients. And if you have a case that is a struggle to you, please think about considering doing and entering one. As always, please protect individual privacy. Don't use all de-identifiable information. We are talking about sensitive subjects in these conversations, so please make sure to be respectful as we are doing that. The key components of an ECHO session are really that knowledge sharing. We have a didactic speaker as well as then a case presentation and feedback. As I mentioned, today we are not having the case presentation. Dr. Camille Fung just brings such a wealth of information about neonatal abstinence syndrome and withdrawal syndrome, and so we want to make sure we all have a great foundation on that. Throughout the chat or conversation, if you would add one reflection in the session or one thing you might add to practice, put that in the chat. That would be fantastic as well. Pre-registration is always a way to get the announcements as well as any of new information. So email us at projectscope@usu.edu. And again, if you want to get credit for attendance, we ask and beg of you to fill out those surveys. We want to thank all of you who have filled out those initial surveys. It helps us be able to gather that information and keep these sessions free and open to everybody. If you have any questions about the REDCap surveys or accessing Canvas, please email Kurt Phillips at USU or projectscope@usu.edu. Kurt, do you have anything you want to say about the surveys?
No, I just want to thank all of you who've been participating in those. They've been better this session than in past sessions. And just thank you so much for taking that little bit of time. There's a little bit up front with the demographic and the knowledge-based survey, but after that, it's just a session survey that really can be done in about 4 or 5 minutes. So thanks for taking the time to do that. We appreciate you helping us keep this open for everyone and free of charge.
Again, case presentation or case narratives, case discussions are a great way to share information about real life situations, hear from our colleagues, and get feedback to take back and apply to our cases. So if you're interested, please reach out to us. Tressa Johnston, our hub member, is also doing active case recruitment. So if you get a contact from her, please respond to her. It's a great way to do it. I'm really excited today to have Dr. Camille Fung talk to us today about NAS and NOWS. She just brings a wealth of information. She's an associate professor in the Division of Neonatology and the Department of Pediatrics at the University of Utah. We're really glad that she's taken the time today. She is on her way to some warmer weather after this. So if you have any questions or anything, you can put those in chat. We are going to be answering those, and she will also answer at the end of our session. If you have not done so, follow us on Facebook or Instagram. We try to put resources and also information about our upcoming sessions. Our April 27th session is going to be Dr. Jamie Meekum, that is going to be talking to us about language and development. And then May 11th, we have monitoring child development and implicit bias. So I'm going to stop sharing and let Dr. Camille Fung share with us. Oh, Camille, you're on mute.
Sorry, having technical difficulty here. Okay. Can you guys hear me and see my screen?
Yes. Perfect.
Well, thank you so much again for the opportunity to speak with this unique group of people. You know, I do inpatient medicine, so I think a lot of times when I send these babies out to the real world, I always worry how they do and how they get along in their development. So I think, you know, in this presentation, I'm giving you sort of how we manage these babies on an inpatient side. But if you have feedback from me as to how to maximize their outpatient, even after we send them home, I would love some feedback, because it is a continuum of inpatient management as well as outpatient. So the topic today is dealing with the epidemic of neonatal opioid withdrawal syndrome, or NOWS is kind of the fancy term nowadays. So let's see if I can advance. It's not advancing for me. Here we go. Okay. I have nothing to disclose. I wish I did. And the learning objectives today, really, I wanted to define for you the prevalence of neonatal opioid withdrawal syndrome, both nationally as well as in the state of Utah. And then we will talk about the clinical features, and you may or may not be familiar with these, but these are the things that we typically focus on in order to try to target therapy for babies while they're inpatient. And you might still see some of these as an outpatient. And then we'll talk about some of the management protocols that are in use currently to manage NOWS, and including the fancy Eat, Sleep, Console protocol that has caught a lot of people's attention in the last few years. So diving into the culprits of all of this epidemic is the opioid pain relievers. And as many of you know, we've seen a surge in opioid use and opioid-related complications. In fact, from 1999 to 2009, there's been a quadrupling of opioid pain reliever prescription sales nationwide. And by 2015, there were 3 times as many prescriptions for opioid-related opioid pain relievers that were filled than in 1999, reaching close to a third of the US adults who are using opioid pain relievers. Because of this increase in prescription, there has been a parallel increase in treatment facility admissions as well as overdose deaths. And unfortunately, since 2011, deaths from opioid pain relievers have plateaued, versus deaths from heroin and fentanyl, some of the synthetic opioids that are lurking around on the streets, have grown exponentially. And in 2017, unfortunately, there were more than 47,000 Americans who have died of an opioid overdose, outnumbering car crashes as well as firearms use. And the CDC estimated that the total economic burden of OPR misuse alone is close to $80 billion per year. And this includes costs of healthcare, lost productivity, addiction treatment, as well as criminal justice involvement. And just for you guys to know sort of some of the potency of the opioids that are being prescribed, We call them short-acting opioids. They are the typical ones that you encounter. They are the codeine, the hydrocodone, and the oxycodone. These are typically prescribed for a legitimate pain control reason, but everyone's addiction threshold is a little bit different. And so some people are just going to get addicted a little bit easier than others. So codeine is about 1/10 of potency compared to morphine. A lot of things are compared to morphine, and you might even hear people saying, oh, this is like how many morphine equivalents? It's because morphine is sort of the standard as kind of the 1x potency. Hydrocodone is just as potent as morphine, and oxycodone is actually 1.5 to 2 times more potent than morphine. And those are the short-acting opioids. Then you have the long-acting opioids, which are typically prescribed to prevent opioid withdrawal. And these are your methadone and your buprenorphine. So because of an increase in opioid misuse and overdoses in pregnant women, this has led to increases in neonatal opioid withdrawal syndrome, or NOWS, as well as increases in injection drug use, which has led to the spread of both HIV and, importantly, hepatitis C has really come back with a vengeance. In the United States, though, there is no universal screening that is mandated during your prenatal lab screens. But I would say, I think many hospitals are now looking at hepatitis B and hepatitis C in their prenatal labs. If a mom is infected with hepatitis C, the vertical transmission is about 6% of infants. And if the mom was co-infected with HIV, it's higher at 11%. And in certain states, for example, such as in West Virginia, they have seen, an increase in hepatitis C infection, doubling to 3.4 per 1,000 live births, and as high as 1 in 50 moms who are now infected with hepatitis C. So why did we change terms, right? It has always been neonatal abstinence syndrome. But because neonatal opioid exposure is so much more prevalent nowadays, the CDC and other sort of governing bodies have decided to actually coin it as neonatal opioid withdrawal syndrome. I would say that many mothers are not just using opioids alone. They are typically polysubstance users. And so even though we change terms from neonatal abstinence syndrome to neonatal opioid withdrawal syndrome, just bear in mind that other substances are typically involved. And then if you actually had pure non-opioid exposures, some of the literature you read may actually call it as neonatal discontinuation syndrome rather than NOWS. And these includes medications such as your antidepressants, your benzodiazepines, and even anti-epileptics. These are all kind of coined into neonatal discontinuation syndrome. Unfortunately, though, babies who have had opioid exposure in utero, as many as 94% of them will develop some amount of withdrawal signs and symptoms. And the severity we'll talk about is actually very hard to predict. So what are the clinical features of NOWS? These are things that I'm sure you've heard of and seen even after babies have gone home. I think of them as categorized into 3 big categories, right? So neurological excitability is one, and these can be manifested as hyperactive primitive reflexes, irritability, high-pitched cry, sleep-wake disturbance, hypertonia, tremors, and the most feared is seizures. Fortunately, this happens rarely in babies who have withdrawal syndrome. The next big category is your gastrointestinal dysfunction. So a lot of babies who are withdrawing actively in the hospital tend to overeat because they are very hyperphagic. They just want to suck and suck. But feeding difficulty is also a sign of withdrawal because they have uncoordinated sucking and swallowing. And babies can also have vomiting and diarrhea as well as part of their withdrawal. And lastly, thinking of like autonomic signs, these are the fevers, the mottling, the yawning, the sweating, the stuffiness and sneezing. they are sort of grouped into the autonomic signs. So why do we focus on these and why do we care? Because of all of these symptoms and signs, these babies are at the highest risk for failure to thrive, both in the hospital as well as once they transition out of the hospital and if they're not well managed. A lot of people will say, well, you know, how do we even figure out which kid is going to withdraw and for how long and all of those things? And I think it's really hard to predict. Because there are so many levels of drug metabolism that is occurring. So the mom's own drug history, you know, how many substances are they prescribed? Are they illicit substances? That is one level. And then the mom has her own drug metabolism. How quickly can she clear the substances that she's taking? And then how much of it actually get transferred across the placenta? Placenta itself has its own metabolism. In fact, the placenta is a really, really smart organ that we tend to just throw out at the end of delivery, but it actually does a lot of sort of screening for things to pass. And then the baby itself has his or her own metabolism, and that partly reflects the dad's contribution as well. So basically, when you encounter a mother who has had drug exposure, baby is withdrawing, it is very difficult for us as clinicians to actually predict which baby will withdraw, even with the same substances, for how long and how severe, especially in light of polysubstance. So I'm going to spend probably the next, 10 slides or so, just to kind of give you a historical perspective of where opioid withdrawal has gone. 10, 15 years. And I'm just going to cite you some landmark articles that have been published. And I think it just speaks to how the neonatal opioid withdrawal syndrome has just really skyrocketed to no surprise to anybody. So this paper was actually published, gosh, it's been 10 years now. It was really a wow paper when it came out. It was published in JAMA. And Stephen Patrick, who is the first author, he's a neonatologist at Vanderbilt University, and you will read a lot of stuff that comes out of him. He really has been the champion, I would say, in keeping track of what's happening with this opioid epidemic for babies. So he published this article, and he took hospital birth data and basically looked at from the years of 2000 to 2009 across the United States, what has happened with the rate of, back then was still called NAS. So I'm gonna just use NAS and NOWS interchangeably for the rest of this talk. So the rate of NAS per 1,000 hospital births definitely increased from 2000 to 2009, and it's about a 3-fold increase during the study period. So back then, the estimation of how often we see a baby with withdrawal is about 1 baby born every hour. Concurrently, he looked at maternal opioid use, the same thing. He saw a 5-fold increase in maternal opioid use. And if we look at the actual mean hospital charges and the length of stay for babies with withdrawal versus babies who were not having withdrawal syndrome, as you can see here, the length of stay is significantly prolonged compared to, kind of a regular hospital birth, from 3 days to, 15 to 16 days of hospitalization. And if you look at the cost, a regular US birth in the past would cost you anywhere from $6,000 to $9,500. But if you had a baby with withdrawal, you're close to $50,000 per hospital stay. And these hospital charges basically were quadrupled, even adjusting for inflation. And who's paying for all of these babies to be managed? And it's the majority of these babies are Medicaid insured. So after that paper came out, 3 years later, another paper came out by Tollier et al., again, trying to describe the prevalence of this issue. What I've learned over time is that until you have publications and actually documenting the prevalence of the problem, you're not going to catch any attention from the US government. And so I think a lot of the authors are just trying to highlight how prevalent this problem is in our country. And so this looks back at the years of 2004 to 2013. Again, these are hospital discharge data. And the number of admissions relating to NAS increased from 7 per 1,000 hospital births to 27 per 1,000. Sorry, not hospital births. These are admissions to the NICU for withdrawal. And again, the mean length of stay at that time was around 13 days, and over time it even increased up to 19 days. And so the total number of NICU stays nationwide attributed to NAS increased anywhere from 0.6% to about 4%. And there were 8 centers who reported in this study more than 20% of their NICU admissions were actually related to NAS. So that's a lot of babies being admitted. And remember, 3 years ago was about 1 hour per baby born with NAS. At this point, it was about every 25 minutes, the baby is born suffering from NAS. And then another 3 years went by, and similarly, a description of how neonatal abstinence syndrome is very, very prevalent in the infants whose mothers have Medicaid insurance. So many of these babies were covered by Medicaid, and there was an increase from 73.7% to 82% of the NAS related births were related to Medicaid patients. And it appears that the Medicaid infants with NAS were more likely to be transferred to another hospital for ongoing care, which again dictated the longer length of stay. And adjusting for inflation, total hospital costs continues to rise for this population of babies. Here, every 15 minutes, one baby is being born with NAS. And this is an article that came out last year, again, trying to describe neonatal abstinence syndrome as well as the demographics for mothers who have opioid-related diagnoses. And so I don't expect you to read through all of this, but I'm highlighting all the rows that I think are interesting to look at in terms of the demographics of these mothers and babies. It definitely looks like it's a non-Hispanic white population that is disproportionately affected, and it's affecting mothers who are in their mid to late 20s. And again, Medicaid is the primary payer for these mothers and babies. And the lowest income quartile, again, are the ones who are affected the most. And these moms are typically in large metro areas. However, don't forget the non-metro areas. We'll dive into that data a little bit in another slide. So looking at neonatal abstinence syndrome alone, again, to no surprise to people, the first description was back in 2000. Now we're looking at the periods of 2010 to 2017. It continues to increase over time. There was
before you go on, people are saying that they are noticing some feedback that's making it hard to hear, and sometimes you get quiet. I don't know.
I wonder if I could go get a pair of headphones. Would that work? And I can speak into a microphone with that.
Yeah, let's try that.
Or let me just maybe it's my heater in the background too. Let me go turn it off. Hold on. Sorry, my basement is cold. I have the heat on. Maybe I'll turn it off and we'll see if that helps.
Okay. That sounds better to everybody. If you could give me, I can't see anybody, so you'll have to put it in the chat. That's the only way I'm noticing. Crystal, will you say something?
My heat should be turning off soon.
Okay, better. So, okay, continue on.
Okay, thank you. Sorry. So going back to, this table where it delineates the neonatal abstinence syndrome, we continue to see an increase from 2010 to 2017. And now And then similarly for maternal opioid-related diagnoses, paralleling the NAS incidence is continuing to increase. And then the length of stay, I want to say maybe there is a glimmer of hope that from those 7 years, we're actually seeing a slight drop in the median length of stay. So it's gone from 12 days average, or median length of stay down to about 10.8 days. And maybe it's because there has been increasing awareness. And I think many nurseries nowadays have, kind of algorithms and management protocols that actually provide consistent care. So maybe that's why we're starting to see a decline in length of stay, even though the incidence continues to increase over time. And for people who are sort of graphic and they like pictures of maps, my husband does, this is actually a kind of a heat map of both the neonatal absence syndrome, the absolute numbers on the A map, and then the percentage change is in the B map. And it just highlights that there are certain states, particularly Oklahoma and West Virginia, that we don't hear a lot about, but they have had a significant increase in neonatal abstinence syndrome.
Great. And Camille, they are still, there's a couple that are still saying you get quiet. So could you maybe try the headphones?
Okay. I will have to run and get them. Just a minute, okay?
Okay. Thank you all for being patient and providing that feedback.
Okay, you guys are gonna laugh at me because these are my son's gaming headphones. Hold on.
Thank you so much for doing that.
Luckily, he's at school. He doesn't know I've hijacked his headphones. Okay, I don't know if that helps or doesn't help.
Well, keep going and then they will let us know.
Okay, all right. Okay, so let's see here. And then I just wanted to do a little self-promoting. No, I'm kidding. This is a paper we actually published from the University of Utah, just to kind of show you what kind of exposures these mothers are actually experiencing. So I had a pediatric resident who worked with me, and we looked at our hospital data from 2015 to 2018. And out of the 175 babies who were more than 34 weeks gestation exposed to opioids alone or polysubstance, we found that 19% of them were exposed to opioids alone, of both short-acting and long-acting opioids. But then 81% of this population who were being treated for neonatal abstinence syndrome actually had polysubstance exposure. And almost half of them were exposed to nicotine. And then again, this is just demographic data to show you that boys and girls are equally affected. Many of these are term gestation babies who are being affected. And many of them have more than one substance exposure. And these are the drug categories that these babies are being exposed to. So short-acting, long-acting, nicotine, stimulants, antidepressants, etc. And interestingly, in our hands, our hospital length of stay actually is doing okay compared to the national data. So when we broke down opioids alone, our median length of stay was about 7 days, whereas many hospitals were, 13, 14, 15 days in the national database. But if you were a polysubstance exposure, you do end up staying longer, on the average about 10 days. And what's also interesting is that babies who have had polysubstance exposure, they tend to require more pharmacological treatment. So that's not been described before. And even with pharmacological treatment, they're requiring not just morphine alone, but they're requiring adjunctive treatment of clonidine or even phenobarbital. And then, yeah, this basically I'm trying to highlight for you here is that of the short-acting and the long-acting opioids, or the combination of both, if you're actually a mother is using both short-acting and long-acting, again, those babies tend to require more pharmacological treatment. And then this is just adjusted odds ratio of, whichever substance you are exposed to, what is your prediction of having length of stay, need for pharmacological treatment, the length of treatment, and the adjunctive treatment. And so this kind of fell out from an analysis, is that if you're using a short-acting opioid like codeine, oxycodone, or if you're using stimulants like amphetamines, you actually have a shorter length of treatment and a shorter need and a lesser need for adjunctive treatment. Not saying that you should go out and use those substances at all, but if you're actually using those substances, you stay a little bit less and you have a little bit lesser treatment need. On the other hand, though, a mom who is on methadone or buprenorphine, which we categorize as long-acting opioids, you're just going to expect that baby to have a longer length of stay and a higher need for pharmacological treatment. Antidepressants the same way, they have a higher need for being in the hospital for. So like I mentioned before, and hopefully you are impressed with the skyrocketing increase in NAS that I've been describing for the last few minutes. The American Academy of Pediatrics actually back in 2012 advocated that every nursery should have a policy for assessing maternal substance use and also have a standardized plan for the evaluation and management of infants who are at risk for showing withdrawal. And this clinical report was actually just updated back in 2020. If you wanted to take a read and you can't fall asleep at night, it's actually a pretty good read. So at the University of Utah, as well as Intermountain Healthcare, we did come up with this management algorithm. And I'm not going to bore you with all of this, but this is basically what we try to follow when we know that a baby has been exposed to substance use. And I think the crux of what we do nowadays, it's changed a lot. People used to focus a lot on pharmacological care, but I think we're starting to realize that non-pharmacological treatment should be the first line therapy. And so what we know also is that if you have had a non-opioid exposure, typically you can get by with just doing non-pharmacological treatment. And so if a mom is only using amphetamines, or she's using amphetamines and she smokes, it's unlikely that that baby will end up needing a medication to actually help with the withdrawal. However, you just have to put the infant's behavior into the context of the type of exposure. So some people will say, well, this baby is super sleepy. Well, the baby's been exposed to, for example, a benzodiazepine, and that actually makes a lot of sense. So I would just say, always know what the exposures are and whether the baby's signs and symptoms actually make sense to you or not. And I think it's really important that we don't just ignore the parents. We should also educate the moms and the dads about what these signs of withdrawal are. Because again, after these babies go home, oftentimes they may have periods of irritability or unable to calm themselves. And so it's good to teach these families right at the beginning what kinds of signs and symptoms are being shown by the baby's withdrawal, and teach them about the calming techniques that work while the baby's in the hospital. These are some of the non-pharmacological care approaches that have been suggested by the literature. So swaddling babies with soft blankets, having a quiet, dark environment, the frequent use of small feedings of hypocaloric formula is kind of controversial. I think knowing that these babies are at the highest risk for failing to thrive, typically they don't just grow on breast milk or formula at 20 calories per ounce. We may oftentimes have to fortify them and give them a higher calorie because they are so hyperactive and they move a lot, and so they're burning a lot of calories. Trying a pacifier, kangaroo care, we know that really works. And then if you are, at the care providers in the hospital, try to organize the care so you're examining the baby and doing cares at the same time and not constantly waking them up. Swings sometimes are helpful, sometimes it becomes too stimulating. Again, you just have to see what the baby can tolerate and determine the level of stimulation that the infant can do without decompensating. And I know some of the developmental therapists have been using this non-pharmacological approach. And so basically you're paying attention to 4 specific domains, and that these domains are, number 1, the baby's reactivity to sensory stimulation and regulatory issues. Number 2, their behavioral states and state control. Number 3, their motor and tone control. And number 4, the autonomic signs of stress. So I would say it's important to take all of these domains into consideration as you try to assess whether your non-pharmacological approach is actually working or not. And then breast milk feeding. So interestingly, the use of maternal breast milk is the most studied non-pharmacological intervention that has been described. However, there are some things that you have to look out for in order to decide whether that mom's breast milk can be used. And first of all is looking at the infectious disease risk. So in high income countries such as us, HIV positivity is an absolute contraindication. That might be different in developing countries where there's lack of formula access and donor milk, things like that. Also check the maternal or the baby drug screen for polysubstance use. Again, the reason we want to know that is just trying to see if the baby's withdrawal signs and symptoms match up with what we think the exposures are. And right now, there is a lot of there's no consensus as to whether a mother who's been exposed to cannabis or marijuana should be pumping and providing breast milk because of potential worrisome for neurological disability from marijuana use on the developing brain. Even though there is no consensus right now, according to the American Breast Milk Society, ACOG, and AAP, they are being discouraged at this point. And then the American Breast Milk Society actually even published consensus guidelines and suggested that breastfeeding should be discouraged if a mother has had a relapse for more than 90 days. And if a mother has not had any relapse for more than 90 days, but discouraged if there's been a recent relapse within the last 30 days of delivery. I think sometimes it's really hard to ascertain exactly when the mother relapsed. And so even though this is a guideline that's been provided, I think practically it's been a little bit difficult to try to carry out. And then if mommies have been on long-acting maintenance-assisted therapy of methadone or buprenorphine, it is definitely safe to allow that mom to breastfeed. It does not prevent the baby from having NOWS, as I showed you in previous data, but some studies have found that it is actually useful to have some of that methadone or buprenorphine in the breast milk. And the concentrations of these medications in the breast milk are really low, and they're not related to the maternal dose. Other good resources, if you ever worry about, what the mother is taking, whether it's safe for breastfeeding, I would say use these two resources that I oftentimes go to when I try to figure out if that breast milk is safe for use. So just a few more words about these different opioids. So the short-acting opioids really have been the culprits of today, and that's why there's been so much drug withdrawal. Like I said before, it's often prescribed for a legitimate reason, but a certain individual becomes addicted more easily than others. And what happens is that as these opioid dependent users have no more access to their prescription medications, oftentimes they would have to temporize and go on the streets and look for heroin. Oftentimes too is that many of these street drugs are not pure one thing or the other. They are typically laced with other substances. For example, fentanyl. I've even seen street drugs that you thought you were getting heroin, but there's some benzo in it. So it's really hard to actually know what these mothers actually getting themselves into from street drugs. And again, polysubstance use is much more common than non-opioid substances. This is a really, really old guideline from the AAP clinical report. They said that if a mother has not had any, if the mother has delivered and it's been more than a week since the maternal dose, it is unlikely that that baby would withdraw. But again, this is based on a very old paper with only 13 observed cases. So don't be reassured that it's been a week out from delivery and the baby's not showing any signs and symptoms. You can still get some late withdrawal that you have to be attuned to. So methadone is the classic long-acting opioid that has been prescribed and is the standard of care for opioid addiction management since the 1970s. It is administered under a medication-assisted treatment program with very, very strict rules and testing. And so methadone actually has been great for mothers with addiction issues, but it sometimes is prohibitive because of the need to travel to methadone clinics first thing in the morning, and the repeated drug testing has been prohibitive for many of these moms, which is why buprenorphine has really come into play nowadays. Buprenorphine is what they call a partial mu opioid receptor agonist. So what that means is that when prescribed at lower doses, it has similar dose-dependent activity as a regular opioid agonist. But as you go up in dosing at higher doses, you actually get a receptor activation plateau. So there's a ceiling effect that just going up on the dose, you're not going to gain any more benefit from it. So it is also additionally, it's also a partial antagonist as well. So it has both agonist and antagonist properties. And buprenorphine comes in many flavors, and you might hear about these different brand names. So there's Buprenex, there's Subutex. These two brand names are just pure buprenorphine. There's no other active additives. But also buprenorphine exists as Suboxone. You might hear about that. And what that is basically there is a 4-to-1 ratio of buprenorphine and naloxone. And you guys might say, well, naloxone is the rescue medicine, right? When you have a person you find on the street that is overdosed, you can actually give naloxone. So why would you actually put that into a maintenance assisted therapy? So what I've learned from the addiction medicine specialists is that they put the naloxone in. It is actually not well absorbed orally or sublingually, so you're not going to precipitate a withdrawal syndrome on the mom. However, it does prevent opioid diversion. So if somebody took this mother's medication and crushed it and injected it directly into their own vein, you're going to get an immediate withdrawal. And so it's really a strategy to prevent opioid diversion. And buprenorphine, even though it's a newcomer for maintenance assisted therapy, it has been pretty well studied during pregnancy. Again, similar to methadone, it still causes neonatal opioid withdrawal syndrome, but it appears that the withdrawal is shorter and milder, and this may relate to the need for a lower opioid equivalent dosing. So all of the talk so far, we've talked about non-pharmacological treatment. And so why is there still a need for pharmacological treatment? Some people may say, well, it's nice to be able to just get by with non-pharmacological treatment, but sometimes the withdrawal is moderate to severe enough that they actually interfere with the baby's physiologic stability, their ability to eat and weight gain, the ability to be consoled, or the ability to sleep. And so basically the most basic things a baby should be doing, the withdrawal is actually interfere with them. And also the ability to have bonding, right? When a baby is freaking out and is crying and is inconsolable, it is very stressful for a mother to have to handle. And so you're preventing the maternal infant bonding as well. So that's when you actually have to use a drug to try to calm that infant. And I would say in the United States, the most common first line therapy is morphine. There are units who also use methadone, but at 80% of the US centers use morphine as their first line. Like I said, other drugs that have been tried are methadone and buprenorphine, and these are sort of the recommended doses. Buprenorphine, because it's a newcomer to the market, it's only been studied in research settings. And one of the drawbacks of having not being able to use buprenorphine consistently across the different centers is that buprenorphine actually have a very high alcohol content. And so that really has disfavored its use so far until the manufacturers can actually make one that has lesser alcohol content. But some of these longer acting drugs have shown to reduce duration of treatment and length of stay. But again, like I said, many of these are only performed in rigorous study protocols and include only women who are in outpatient treatment. So the generalizability is a little bit unknown at this point. And then I just wanted to show you, in addition to morphine, even in our own hands, we use clonidine or phenobarbital as our adjunctive medications if morphine is insufficient. And we pick one or the other based on whether it's a predominant opioid exposure versus it's a polysubstance exposure. If it's a polysubstance exposure, typically phenobarbital is our go-to medication, whereas clonidine is the one that we prefer when it's pure opioid exposures. So again, how do we predict how long the baby will stay in the hospital? It's really, really difficult. It is highly variable. And I would say the discharge criteria should really focus on the lengths that the baby can sleep, the ability for the baby to gain weight, and the ability to be cared for by a reasonable lay person. So being able to sit with that baby at the nursing station and rocking that baby all day long is probably not the ideal situation. And so that baby's withdrawal is definitely not well controlled at that point. In addition, I think we have to assess the safety of the home environment to make sure that that baby is going to be okay going home to whoever the care provider is. And that also should be one of the discharge criteria that has to be assessed. And also take into consideration of the developmental age of the infant. I often find ourselves in the NICU, the baby's 2 to 4 weeks of age. For example, they are still sitting in the NICU withdrawal and the lights are down, the curtains are down, and it's broad daylight outside. It's probably not going to help that baby transition to the outside world if we continue that kind of activity. We really need to start thinking about their developmental age and start to transition them away from just being in the dark all day and all night. And interestingly, following a standard treatment protocol with stringent weaning guidelines will actually reduce the duration of opioid exposure and length of stay. So having, just kind of a consistent care approach alone, whatever drugs you decide to use, whatever non-pharmacological care you decide to perform, just having a standard protocol is going to reduce the length of stay. So I think that is really helpful to know. And then the last few slides I wanted to show you is this Yale's Eat, Sleep, Console protocol. It caught a lot of attention back when it first was published in 2017. So it's been 5 years, and I would say that it's still, research in progress. Not every hospital has adopted this, but when it first came out, Dr. Grossman is actually a hospitalist at Yale. And he decided that, it's probably not a good idea for these babies to be stuck in the NICU. Parents cannot stay at the bedside, and they cannot do non-pharmacological approaches well. So he assembled a multidisciplinary team in February of 2010 and came up with some of these key interventions that he was going to institute over the next 5 years to try to see if we can get by with doing non-pharmacological approaches a lot better and using non-pharmacological care only as needed. And so he standardized the non-pharmacological care coupled with empowering messages to parents. They developed novel approaches to assessment. So rather than actually scoring the babies based on different scoring systems that are actually kind of archaic, they canned all of that, and they just go by the ability of the baby to eat, sleep, and console. And like I said, administration of morphine is only as an as-needed basis if non-pharmacological approaches fail and the babies don't go into the NICU. They actually go into an inpatient room where the caregivers can stay with them at the bedside. So their definition of ability to eat, sleep, console, this is what they defined as: if a baby can effectively breastfeed or take more than an ounce from the bottle per feed, that's a success. If they can sleep undisturbed for more than an hour, that's a success. And if they're crying, if they can be consoled quickly within 10 minutes, then that's also a success. And if those things are achieved, then you continue doing what you're doing and you don't pull out your morphine. However, if any of these things fail, the caregiver team will actually huddle and go over, did we maximize all of these non-pharmacological approaches that we have talked about? And if not, we should maximize them. And if everything has been maximized and you're still having a lot of withdrawal signs and symptoms, then that's when your morphine will be initiated. And what they found with 287 infants was that they were able to decrease their average length of stay from 22.4 days down to 5.9 days. And the proportions of methadone exposed infants requiring morphine decreased also from 98% to 14%. And the cost also dropped by about 3/4. And in the short-term study, they did not see any adverse events, and there were no even admissions to the hospital. So because of this study, and everyone was sort of, really excited about the adoption of it, the NIH said, hold on, everybody, why don't we actually study this rigorously across many, many centers in the United States and see if we can actually do this in a systematic manner. And we should have a long-term follow-up program of these babies to see if doing this ESC approach is actually not harmful. So being at the University of Utah, we were actually able to participate in this NIH-funded eSleep console study. And I was really, really excited and wanted to kind of jump on it right away. So it's appealing because of its ease of use and its simplicity. And because it has not been studied outside of QI initiatives, we do not know the generalizability. So I wanted to make sure that we were, Utah got on the map for this. And also, is the improved length of stay attributable to the approach of the ESC, or is it just because of better adherence to non-pharmacological approaches? That alone can reduce the length of stay. So that's a question that we're trying to answer as well. And I just love that they are actually spending time to follow up these babies. As many of you know, following these babies in a longitudinal fashion is very, very difficult because of, mothers they're not able to bring the babies back, or they're moving all the time, or they actually lose custody to the state. And so this NIH trial actually has a 2-year follow-up with frequent surveys given to the caregivers and questions about their ability to cope and the infant's ability to cope. And they have planned neurodevelopmental exams with the Bayley scales up to 2 years. So these are the lead study investigators. These are all people who kind of our champions for this Eat, Sleep, Console study. So you'll hear Leslie Young from University of Vermont, Lori Devlin from University of Louisville, and Stephanie Mahar, University of Cincinnati. They're kind of the leads for this. And so I wanted to also give you some caveats as to why it's not something that you could just adopt nationally right off the bat, even though it seems so promising. So far, the hospitals that have adopted this Eat, Sleep, Console care approach has had a very large proportion of their mothers who are receiving medication-assisted treatment, either with methadone or buprenorphine. Unfortunately, in the state of Utah, many of our mothers are actually not in any kind of organized treatment program. It's getting better over time because of different efforts put out by the state, but I would say this is still not the norm for our mothers. And at this juncture, the potential effects of the Eat, Sleep, Console care approach on infant safety and infant and family well-being following discharge are unknown. So maybe actually turns out to be worse by withholding pharmacological care in these babies. So that's why we must study it in a rigorous fashion. And so the primary hypothesis for the study was that if we did this correctly and properly, we should reduce the length of time when the baby's ready for discharge by an average of 4 days. And that this use of ESC care approach would actually improve infant neurodevelopmental outcome and improve family well-being. So that's what we're trying to figure out. So, you know, it's when I presented this like six, 7 months ago, we were just starting this process. And I want to say we finally completed at this point. So University of Utah, we were randomized to block 5. So what that means was that when we started, we just continued our usual care. We just did what we have been doing for years. And then we had a transition period back in June of last year where we were trained, the nurses were trained. This, as you can imagine, this is very, very nursing driven. And they teach the families how to do this. And so there was about a 6 to 8 week of transition period. And then we switched over to ESC, and we just completed the entire study at the end of March. So now in the 2-year follow-up, and we'll actually have to see what happens over time. And then lastly, I would say before we discharge, these are this is a checklist that was put out by this AAP clinical report, and I love it. I really wish that we would stick to this at every infant's discharge because it addresses a lot of inpatient as well as outpatient follow-up that needs to be done. So parent education, do you have a primary care provider that can see that baby within 48 hours of discharge? Our early intervention services referral made. If home nurse visitation referral is warranted, is that made? And again, hepatitis C follow-up testing should be done because again, many mothers are now coming up with positivity for hepatitis C. So that baby needs to have testing done at 12 to 18 months of age. And is there a plan for safe care, coordinating with child welfare and DCFS if needed? And also, if the baby is falling behind, is there a format for developmental and behavioral pediatrician to be involved in that baby's care? So I think all of these things should really be thought through before a baby is discharged. And some people have asked me, how do you counsel mothers and how do you expect these babies to do in the long term? And I think this is a question that is really difficult to answer because it is difficult to disentangle the short and long-term effects of exposure to opioids alone or to opioids and other substances. And it's not just the drugs alone, right? There are many social and economic factors that have to be taken into account. There is systemic racism. There is maternal, physical, and mental health. There are epigenetic and genetic factors. There are nutritional factors. There are environmental factors. And all of these in concert will affect the infant's neurodevelopment, independent of their mother's substance use disorder. So I think it is just really, really hard to kind of predict how that baby will do. They are definitely at higher risks, but what are those risks? I think it's just not well known. So my 2 cents is that all babies with opioid exposure, regardless of whether they need pharmacological treatment or not, are at increased risk for developmental alterations, and we should refer to early intervention. And again, we should refer to home nurse visitation programs if we feel that there is a need for that particular family. And pediatricians, who are taking care of these babies as outpatient, definitely should refer to early Head Start programs. And you guys know this a lot better than I do, targeted for pregnant women and infants until 3 years of age. And then there are a whole host of other developmental resources that people can refer to on these websites. And that's it for my presentation.
Camille, thank you so much for all that wonderful information. Oh, I just lost my chat. So there is, you can see one thing in it. She's just saying, I love this. Our daughter was sent home from the hospital on day 2, even though the birth mom tested positive for many different drugs. Parents need this information. So,
yeah, so as part of our algorithm, and again, I hope different hospitals are formulating their own plan of management, but if a baby has had short-acting opioid exposures, we actually ask the baby be watched for up to 72 hours. However, if there is a long-acting opioid exposure, we ask that baby to be watched up to 96 hours. Again, to ensure that the signs and symptoms are, even if they have them, they are manageable by the caregiver by the time that baby goes home.
and then, so we're just going to open it up to a few minutes of questions. If anybody has any, there's another comment in there from Pat Boyle that says, thank you, Camille. They are doing GMA testing prior to discharge at UUMC.
They are, as far as I know, they're not routinely doing GMA testing. And for those of you who don't know what GMA is, the General Motor Assessment Testing is a tool that has been adopted by our neurology group at the University of Utah. Right now, I think the woman power available is only for preterm infants, but I think that as caregivers, if we have particular concerns for a baby not showing proper signs of motor development, I'm sure the developmental team would be willing to do a GMA. And the GMA testing, as you know, is just one point in time. It just gives you information about what the baby looks like at that day of testing. It's you need to continue to follow that baby and continue to do more GMA testing in order to predict, particularly for cerebral palsy. That's what the GMA testing is for.
There's another question from Julia that says, can you touch on scoring tools for symptoms and whether these apply to infants exposed to substances other than opioids?
Yeah, thank you for that question. I get that a lot, actually. So, the classic scoring tool people use is the Finnegan scoring tool. The Finnegan scoring tool, when it was made in the 1960s by Loretta Finnegan, who's a nurse, I think it was 39 items, something like that. It was just this massive amount. And when you have a baby who's screaming, withdrawing, trying to do 39 items, it's almost impossible. So then they came down with the modified Finnegan scale, which is still, I think, 17, 18 items. So it's still pretty cumbersome to do. But that is actually what many hospitals across the US is using, is the modified Finnegan scale. At the University of Utah and at Intermountain Healthcare, we actually use something called the NWI, the Neonatal Withdrawal Index. And that's only 11 item. Easy for me to say, 11 item, easy to score. It's 11 items that the nurses have to go through in order to give it a score. Anything less than 7 or less, we think that we can continue with non-pharmacological treatment. But if a baby scores 8 or higher, then they warrant a pharmacological treatment. So that's why this Eat Sleep Consulting caught on, is because you're canning all of that. You're not spending all your time trying to figure out, is this a hyperactive Moreau or is this a non-hyperactive Moreau? People are just looking at eating, sleeping, and consoling. If you can do those things, you're good to go. So stay tuned. We'll figure out whether this care approach is actually the same as the Finnegan scoring, or is superior. Hopefully it's not inferior. Does that answer? And then, sorry, one more answer to it. So if you have a non-opioid exposure, typically I will tell my nurses that you can score if you want, but because many times they don't need a drug to treat, your scoring typically is going to be 7 or less. So you can if you want to, but once you add up all the symptoms, it's typically you don't need to use a medication. Does that help?
Yeah, I have a quick question for you. Thank you for all that great information. Mine is more early childhood focused, but I'm wondering, are you following these children past their infancy?
I am not, because I'm a neonatologist, so I practice inpatient medicine. And I wish there was a mechanism where these babies, for example, can go to a long-term follow-up clinic. For a lot of preemies, we have that ability to send them to the UDAC, right, University Development Assessment Center, and they get followed long-term. But it's hard for me. I want to say I wish there was a formal way of following these babies. There's just limited resources available. And so it oftentimes falls into the laps of the pediatricians or the family medicine doctors who are seeing these babies. And hopefully they have enough training and really comfort to say there is something wrong and we should refer. But it's hard to know for me out in the community how these babies are being tracked in the long term. I love your guys' input. You can educate me as to what you're seeing for this particular cohort and how we can do it better to make that transition.
Now we have quite a few early child care providers on there. Does anybody have any suggestions? Or, oh, Pat, I think I see your hand up. So
yeah, I'm trying to find the place where you put your hand up, but I always forget it. I've always felt that if we as early intervention people, we talk amongst ourselves. So these families are traditionally, they move from place to place to place. They move into different districts, but I'm just wondering if we can collaborate with DCFS, because a report is open on all these children and their families if they've prenatally exposed their baby. So I just think it needs to be tightened down, and it is a government thing. We need to say to our government, we need to follow these kids.
Yeah, so it's interesting you bring that up. So because I'm the principal investigator for this ESC study, and many, at the university, 50% of our babies actually become DCFS custody. So when I approach them to see if we can continue to follow, because right now, if a baby becomes custody of the state, I am not allowed to continue studying that baby. So for the last 9 months, I haven't fought with them, but I think I've been a thorn on their side, trying to advocate that these babies need to be followed, especially if the mother consents them into a clinical trial. We should have the ability to continue to see how that baby develops over time. So after a lot of emails and going through IRB application, we now have the ability to actually follow these babies who are enrolled in the study, to actually bring them back for developmental assessments. But that's only in a clinical trial setting, right? So many moms who did not sign up for our study, I don't have any mechanism of seeing how those babies do. That's the sad piece.
because Crystal talked about She put in the chat, in Arizona, there's a nursery called Hushabye Nursery or Hushabye Nursery that is doing a lot of great things with parents with NOS and babies in the modified center. She put a contact if you would like to collaborate. Crystal, I don't know if you want to share anything more about that.
They just opened up probably 2 or 3 years ago, but I just recently watched kind of a follow-up, and they had actually parents that came in and participated, and they put together a binder that helps them organize all of their things. They contact parents prior to birth as often as they can, and then the babies go directly from the hospital to this nursery as soon as possible. They do a lot of skin to skin, and that you know, the center is very calm and quiet, but they work with the moms and the babies in long term, and it's just been really, really great outcomes for their little cohorts just over the last few years that they've got going. And I noticed on that map, Arizona was one of the darkest, and so I'm sure that's part of it, but some really great things have been happening, so probably can
Yeah,
learn.
I was gonna comment that Vancouver, actually, Canada, they have a similar program where after discharge from the hospital, the families actually get discharged to this particular family center where the whole family lives there until the baby's withdrawal is, not a big issue. But I just wish I had endless amount of dollars and resources and lots of really caring people who can put a center like that together. But I think that these families oftentimes are ostracized. They are not the people's priorities. And so that's hard. That's really hard.
It certainly is. Go ahead.
Can I ask a quick question? So I'm the one who posted about my daughter that was discharged like too early. And she had some severe symptoms, withdrawal symptoms, you know, the jitteriness. She cried nonstop, didn't sleep well. She ate okay, but it was nonstop holding her and rocking her, moving around the house, trying to get things done. It was a really hard process, but it lasted for a really long time. You know, the withdrawal symptoms, they say, you know, maybe 2 weeks, you know, 1 to 2 weeks of withdrawal symptoms, and they should be moving forward after that. But she was irritable and fussy and all of that for a good 2.5 to 3 months. And I just wondered, is it still considered a withdrawal, or is that just more effects of the withdrawal? Does that make sense?
Absolutely. And I wish I could tell you is one way or the other. I think when you are 2 to 3 months out, to me, you're probably seeing the effects on the brain itself and not as much as the withdrawal. So I actually got a phone call from a mom. Her baby, you know, she's a foster parent, and her baby, I think he was 6 months old, and he was still having periods of irritability, inconsolable crying. And I ended up actually referring him to our pediatric neurologist, because at that point, to me, is you're probably not just dealing with in utero exposure anymore. I think it's probably the manifestation of the long-term exposure on the brain itself. And I sent him there to be assessed by the neurologist. I don't know what the actual result ended up being, but I know like a brain MRI was done. There was an EEG done to really look at, are there any organic brain causes that is still lingering along, and it is now has nothing to do with withdrawal. So I think you have to almost be kind of pushy with your caregiver and with your pediatrician and say, this is not normal. Like, who can I go to get help with this? Because this is not just drug effects anymore.
And I probably should have been more pushy, because no matter who I talked to, you know, they were always very clear. Well, she should be over her withdrawals now. So things should be calming down, but it was a hard battle. And she still has a really hard time once she's lost it. Like it takes her 10, 15, 20 minutes of blood curdling screaming for her to be able to calm down enough for us to even work with her on it.
Yeah, I mean,
So I should have been more pushy.
I always tell parents to be pushy. I truly believe that the neurochemistry is altered by the drug exposure, and so as your brain tries to normalize and make connections and synapses, it cannot do it properly because of the early exposure. So I really think that if by 3 months, 4 months, 5 months, 6 months, I would say the drug withdrawal piece should be a minority of the brain at that point. I would really worry that there's something that has been miswired or somehow something has gone wrong with brain development in general. I remember
Oh, go ahead.
No, I was going to say, I remember this one baby that I'm talking about. The neurologist ended up putting her on gabapentin. It's a drug just to help the brain normalize, so you're not so kind of jacked up all the time.
Right.
And so I mean, I know it's terrible to treat with another medication, but it helps to just kind of bring it back to normal function, if you can see what I mean. Not so that you're not spending a half an hour just to calm her down before you can move forward.
Right. As a 4-year-old now, is that something to consider? Like,
Well,
would that still be something that you would try to get, or?
I would say I would have your daughter be assessed by a developmental pediatrician.
Okay.
And see if there are other things, right? Maybe she has anxiety. Maybe she has other mental health issues that are not addressed right now. And that's what it's morphed into, right? And so I would just ask your pediatrician for a developmental pediatrician referral and actually do a full assessment and decide what is it that she is needing to help her to help her maximize her potential as much as possible.
Thank you. That's great advice. Appreciate it.
And I think that's always a great point that you guys just were talking about as we move forward with things. These kids don't always hit those big milestones that or delays in the areas that we typically see with developmental delays. And so looking at what are some of those long-term impacts or effects of that. And a lot of it is that emotional disturbance. And so that's a great recommendation, developmental pediatrician. Tressa, I could see you're unmuted.
Yeah, I just it just kind of brought up that as an early interventionist, I've seen a couple of babies where I don't know the dosage, but the moms were taking antidepressants and had similar effects with babies being unconsolable the first 2 to 3 months. And is that a withdrawal from the antidepressant, or is that they're not making their own neurotransmitters that they need?
Yeah, I would say it's probably a combination of the two.
Okay.
Again, there is so much that goes on in utero with brain development, and oftentimes it goes just fine. But when it doesn't, and you're trying to figure out what has gone wrong, that's really hard to figure out, because again, it's hard to disentangle the in utero drug effects, or is it because of the drug effects have now altered the trajectory of that brain development? So now you're not able to normalize. It's hard to figure out. I was telling Janelle earlier, I actually have a research lab looking at brain development in a mouse model of growth restriction, because we know so little about what happens with the brain with perinatal insults, right? I am not going to be able to get a fetal brain biopsy from a mom. I don't think any mom would consent for that. So I had to develop a mouse model to try to understand even with IUGR, intrauterine growth restriction, how does that change the brain during development? That's an enigma that we don't have good understanding of. We just know that, yeah, the brain is changed. That's great. But what are the cellular changes? What are the molecular changes? How are these actually going to make that kid at higher risk for postnatal life? So I was making a plug to Janelle that if you can donate a few dollars of your tax dollars to my research lab, I would love it. But I just submitted an NIH grant to try to fund my lab to study this particular problem. And maybe if I can figure out IUGR, maybe another perinatal insult like NAS would behave similarly. I don't know. But that's at least one way of trying to get at what happens with the brain during these active insults.
Yeah.
Yeah, thank you.
And then, I lost that. Pam also says that the Utah School of the Deaf and Blind now is doing a assessment for the little ones coming from the NICU, looking at potential risk for vision issues based on neurological issues, and children with NAS can have vision issues, so vision processing. So that's another great resource. And anything you want to share with us, Pam, on that?
Hi, sorry. Yeah, I could just sit in the car, listen to this great webinar today. It's called the Neonatal Assessment Visual European Grid, and we were trained on it from the folks from the Anchor Center of the Blind in Colorado. And it's just a great little tool just to assess these little ones that are under 12 months old that have come out of the NICU, just to see what those potential risks are and just their visual responses. And yeah, and those little kiddos who have the NAS, we're seeing some of those things as well, with just how they respond visually and just that sensory overload, and just things are just too much through the vision system too. So just a nice tool.
Yeah, I almost wish, like, I don't know, Janelle, this is my wish list, if we could have like a summit and pull all these people's great ideas and kind of come up with a wish list for the state. With this kind of follow-up clinic, what does it look like? Who are all the people that need to be involved? It would be so great to be able to send every NAS kid to this follow-up clinic.
Right. And I
across
know
the
that,
state.
yeah, that would be so amazing. I know at one time I should gonna connect you with Kelly Kohler, because I know that she was getting a state group together, and I'm sure that COVID has stopped that. Kelly, are you still on and listening?
I am.
Oh, I was like, your name moved. So I was like, maybe you jumped off as soon as I said your name.
Of course. Yes, you know what? I've kind of pivoted because this efforts has continued, kind of seeing this more as the state team. We did start a state team. We had a couple initiatives like media campaigns that a few like Children's Society and Carney took on, and that people got a couple of grants from the AAP. And we had a Head Start program that did. And so through those efforts, we had some good media campaigns and trainings. But then, like you said, with COVID, and then I just kind of pivoted to participating on this, just to kind of keep my finger on the pulse around the statewide efforts for it, because we kind of finished a couple of the projects there. But I would love if we need to restart it again, if we should open it up, this is such a great representation, diverse group, if we should, I don't know. Anyway, just a thought, because I think there's so many people here. There's no reason to like duplicate efforts,
Yeah.
but would love to continue to do things around media campaigns and stuff like that.
So we should all get.
I do.
Okay. Well, you guys, we are running out of time. I know we could all just rack Dr. Camille Fung's brain for the next little while on it. So thank you again for everybody joining and participating. Look out for your surveys. And then our next session will be on April 27th, and hopefully it won't be snowing where I am at on that day, to hear about language development in these young children as well. So thank you very much for your time, and thank you, Dr. Camille Funk, for all of your information.
Thank you. It's always a joy to speak to this group.
Thank you.